Part of Dr. Sriman.
Good afternoon. Today I'm going to present topic on ocular manifestations in chronic kidney disease patients attending a tertiary care health center, a cross-sectional study. So, CKD is decreased kidney function or markers of kidney damage or both for at least 3 months. So, either because both, so here both kidneys and eye can be involved, so either because of both organs are the target of the same disease process or because the ocular disease is a result of renal involvement. So, oculorenal disorders. So, this includes the kidney diseases. The manifestation can involve the eye also. So, either it can be malformations, ciliopathies, structural defects, can be metabolic, phacomatoses, vascular. So, these are certain examples in malformations. So, here we can see in Weger syndrome. So, there is Wilms tumor, aniridia in eye. There is involvement of eye. This is aniridia. Then genitourinary abnormalities. In Church syndromes, there is coloboma involving, this is retinal colobomas. There can be renal abnormalities, heart defects. In Alagille syndrome, so there is posterior embryotoxon. In structural, there is Alport syndrome. So this is eye involvement. There is lenticonus, anterior lenticonus. Microchoria in Pearson syndrome. Zellweger disease, there is pigmentary retinopathies. Can be metabolic, there is involved Lowe syndrome. So there is cataract. Cystine crystals in cornea in cystinosis. Cataract in galactosemia. Hemangioblastomas in von Hippel-Lindau disease. In tuberous sclerosis, astrocytomas. There can be either diabetic or hypertensive retinopathy changes. Also, there can be metastatic calcifications, cataract, dry eye, IOP elevation, retinal detachment, or optic neuropathy changes. So, our aim was to assess the ocular status in patients with kidney disease. So, objectives to screen ocular manifestations in patients with CKD and to detect any changes in retina using OCT in patients with CKD. So, this was a cross-sectional, non-interventional, descriptive and hospital-based study involving Department of Ophthalmology and Nephrology in our tertiary care center. So, the sample size was 70 patients with chronic kidney disease. So, the inclusion criteria, patients with chronic kidney disease with a signed, written, informed consent, above 18 years of age, high quality OCT images. Exclusion, reversible renal failure, renal transplant patient, pregnant patients, patients with ocular trauma or surgery. So we selected 70 patients with chronic kidney disease from our nephrology department and detailed history and examination done. So these were the results obtained. As we can see, so in LIDA and NEXA, 95% patients were normal with 4.3% showed lid edema. In conjunctiva, 45% were normal, 45% showed pallor, the rest showed pincecula. Lens, normal, 80% were normal, 20% showed cataract changes. Shimmer test showing dry eye in 8% of patients. In case of retinopathy changes, 52% were normal. The rest showed different stages of hypertensive retinopathy changes. 28% patients with there were no diabetic retinopathy changes. The rest showed different stages of diabetic retinopathy. 5.7% showed branch retinal vein occlusion. Only 1.4% showed central retinal vein occlusion. So this was the mean IOP range. IOP right eye where mean range was at the range of 14.29 and left eye 14.13. So this was association CKD and BRVO in patients according to the stages of CKD. This is moderate, severe and end-stage renal disease. And only 1% patient showed CRVO. So discussion. So development of the kidney and retina occur at the same embryonic stage. So both the glomerulus and choroid have extensive vascular network of similar structure. So inner retina and glomerular filtration barrier share similar developmental pathways. The arrangement of retinal pigment epithelium, Bruch membrane, and choroidal capillary endothelium resemble glomerular endothelium, glomerular basement membrane, and podocytes. Also, renin-angiotensin-aldosterone system is found in both the kidney and various ocular tissues that regulate the blood volume and systemic vascular resistance. And diseases involving the type 4 collagen can affect both eyes and kidneys, resulting in retinopathy and nephropathy changes. Also, advanced glycosylation end products cause cross-linking and insolubility of lens proteins, yellowing of the lens, and accumulation of glycation end products in the lens, contributing to its role in the formation of cataract. So diabetes mellitus also affects both the ocular and renal vascular bed. So diabetic retinopathy is characterized by the presence of retinal microangiopathy and ischemia. Arterial hypertension is a significant cause of visual morbidity in patients with chronic renal failure. So conclusion, there is a substantial evidence of a close association between eye and kidney disease. The involvement of the eye in renal disease can be either because both the organs are the targets of the same disease process or because the ocular disease is a result of renal involvement. So recognition of overlapping pathophysiology between the renal and ocular disease helps in prompt diagnosis and treatment of patients with potential ocular and systemic morbidity. So these are my references.
Findings are normally seen, no? Any chronic problem along with the diabetes. You can see the fundus findings and all. Complications are almost same. See, the findings you are told, they are not new. They've been accepted for so many years. But I want to know that you are told about Lowy syndrome and all. You have mentioned, no, Lowy syndrome.
Love syndrome. Yes, yes, sir.
Love syndrome or whatever syndrome. You mentioned, no.
Yeah, mentioned.
Do you know something about that syndrome?
Oculocerebral renal syndrome.
Very good.
In ocular, there is
You are appearing for exams.
next year.
Next year, then okay, we can ask questions. No problem.
There can be cataract.
You tell me, what type of inheritance is this? Autosomal? Huh?
Mitochondrial.
Okay, I will tell you one thing. You are having Lowy syndrome. Is it correct or not? I'm telling you now, you are having Lowy syndrome. No, how do you know? You must tell, sir, it's an X-linked recessive problem. I'm a girl. I'm only a carrier. Whether you must tell in exams. Are you to follow? You know, one more thing, beauty of the Lowy is what? Both congenital cataract and congenital glaucoma may be coexisting the same patient. That's what the peculiar feature of that. I don't want to ask about the enzymes and all. They will get confused, so much confusions.
Most important clinical thing what you think about CKD and IS, if you think about all patients with CKD, they do have some amount of anemia, right? They can have optic neuropathy. So unexplained vision loss or dyspallor with no significant vision loss, always rule out anemia in these patients. So you need to intervene accordingly. Okay, so temporal pallor, but the vision is good, always rule out anemia in these patients. This is what you should learn. Any patient CKD, systemically evaluate them completely. The most common manifestation is optic neuropathy only.
Certain disease pairs are vicious cycles. One disease affects the other affects the same. CKD and diabetic retinopathy are vicious cycles. As diabetic retinopathy evolves, secondary hypertension comes and complicates it. Uremia complicates it. Anemia complicates it. When I heard this topic, I thought you'll delve into those things. Those are the key factors which are affecting day-to-day practice in ophthalmology setups here. Lowy disease will be, of course, yes, but very rare. Trying to associate all the congenital anomalies and systemic anomalies with the CKD. CKD is a burning disease. It's not a dormant disease. So when you think CKD, then you think emergencies, you think crisis, you think issues where electrolyte imbalance comes and complicates a macular edema. That is what you should think about. Okay. So restructure your thing and think in those lines.
Thank you, Dr. Srimu. The next speaker is Dr. Nayana.
Good afternoon. My topic is role of spectral domain optical coherence tomography in blunt ocular trauma patient, a cross-sectional study. So introduction in blunt ocular trauma, damage is caused by direct contusive force or counter coup injury, and the main causes are road traffic accidents, sport injury, physical assaults, workplace or home accidents. Traumatic maculopathy due to closed lobe contusion can manifest as commissuretino, traumatic macular hole, indirect choroidal rupture, in retinal damage or pigmentary changes. And the aim is to evaluate microstructural changes in macula following blunt ocular trauma. And the primary objective is to evaluate these microstructural changes in macula following blunt ocular trauma. And the secondary objective is to evaluate the usefulness of SD-OCT in blunt ocular trauma by assessing the early microstructural changes in macula. So this materials and method, it's a cross-sectional study which was conducted in Department of Ophthalmology and Emergency Medicine with 60 patients with blunt ocular trauma. And the inclusion criteria, patients with blunt ocular trauma who give informed consent and by obtaining high quality OCT images. And the patients with lens and media opacity and with traumatic glaucoma was excluded. So methods of data collection, 60 patients with blunt ocular trauma patients were taken and detailed history and examination was done, and OCT macula and RNFL, OCT RNFL was taken. So from this, the result was the distribution of patient according to sex is about 53% were male and 47% were females. And the distribution according to mode of injury, about 33% having RTA, and having those who have got blunt ocular trauma with object greater than orbitis was about 17%, and object less than of orbitis 50%. So in visual impairment, in this case, 45 having with visual impairment and 15 having without visual impairment. And the frequency of macular changes were classified as foveal and extrafoveal. So from this, commercial retina has higher frequency. So this is the bar diagram showing that having commercial retina having 18 extrafoveal and 12 foveal cases. So rest having choroidal rupture, macular hole, retinal pigmental changes, and retinal detachment. And in this, we included traumatic optic neuropathy, having 10 patients. So these are the OCT pictures showing retinal pigment epithelial changes with ganglion cell complex loss and RNFL loss. So these are the pictures. And from all these things, there is a circumpapillary RNFL analysis. I have taken during presentation time, case and control I was compared, and there was a thickness CNFL RNFL thickness in the affected eye show reduction when compared with the contralateral control eye, but on statistical analysis it was not significant. So this is the bar diagram showing that. And also ganglion cell complex analysis also the same. There is a thickness is reduced when compared with contralateral control eye, but on statistical analysis it was not significant. So it's a bar diagram showing that. And on discussion, commercial retino is the most common finding in the blunt ocular trauma patients. And OCT changes, we have seen there is a reflectivity of change in reflectivity of the retinal layers with variable increased reflectivity from the inner retinal layers, and there's an increased reflectivity of the inner segment outer segment junction. And the retinal pigmental epithelial changes presented with yellowish hypopigmentation macula sparing the fovea. On OCT, there is an area suggestive of outer lamellar translucency, which was likely to correspond to an area of photoreceptor disruption. And this is a case of traumatic optic neuropathy. This shows thinning of the ganglion cell layer in left eye. And on choroidal rupture, there is a both pattern. There are two patterns are observed. There is first pattern is a forward protrusion of retinal pigment epithelium choriocapillaris with an acute pyramidal dome shape. And second pattern, large disruption of choriocapillaris retinal pigment epithelium, ISOS external limiting membrane with a depression in this area or downward sliding of tissue into this defect. And also in Macular hole, there is a partial thickness defect of outer retina at fovea with intact inner layers. And retinal detachment and OCT reveals separation of neurosensory retina from the retinal pigment epithelium. So conclusion, SDOCT proved to be a useful tool in the evaluation of patients with blunt ocular trauma. On OCT, circumpapillary RNFL and ganglion cell complex showed thinning in severe cases, but compared with normal eye, it was statistically not significant. And most of the foveal involvement was in the form of commissuretino. Extrafoveal involvement was in the form of choroidal ruptures and retinal pigment epithelium alterations. So majority of patients had good visual recovery except those with severe foveal damage with poor prognosis, which was accounted by using SDOCT. Thus, OCT is a vital tool in detecting subtle microstructural changes and therefore helps in evaluation and management of posterior segment manifestation following blunt ocular trauma. So these are the references. Thank you.
Okay. You're told about Kamoshi retinol, no? How many patients had Kamoshi retinol in your study?
So those are including foveal. I classified into foveal and extrafoveal. In that, extrafoveal is about 18 patients, and foveal I have got 8 patients.
That foveal patients, what about the visual prognosis in those cases? You followed up the patient, no?
My study, I didn't follow up much of the patient because my study was cross-sectional. So
Normally we expect, the patients to recover better. All these Kamoshi retinal patients can recover very well. It's called as otherwise what's it's Berlin edema, you know that?
Berlin's edema, sir.
Why it's called Berlin edema?
If it affects on the macula.
No. Why it's called Berlin edema? Berlin, the
Yeah.
city. Where is it? Berlin Wall. That means you know that East Germany, West Germany, like that we have got. In this case, why it's called Berlin edema? You tell correctly. Madam is waiting. Donate. Hey, donate 1,000 rupees, ra. Last chance. Hey, one more chance. Last chance. If you tell why it's called Berlin, she has given me 1,000 rupees now. I'll donate you now itself. You want dollars, $1,000. 1,000 rupees is nothing. So naturally, 1,000. Hello. You don't know. Berlin doctor's name, man. Ophthalmologist name. That fellow found out the problem and he wrote this. That's all. That's why it's called Berlin's edema. It's not because of Berlin and all these things. City. Nothing to have connections. It's just for information. Don't worry. Okay.
After how long after the trauma was this OCT done?
Actually, I have done after seeing the patient emergency department. I took the patient
No,
to the
the question is how many days after the injury? Because with time, OCT findings are going to change.
Sorry, ma'am.
You take carry on.
Ma'am, actually, if the patient is stable, and I took the patient to the OCT at that moment.
Was it an acute injury, chronic injury? What was your patient selection? And this, how is it going to practically transform your management of the trauma?
By taking OCT, I can find out some subtle microstructural changes. If there is thinning, ganglion cell complex thinning, or RNFL thinning.
How soon does this thinning occurs?
In some acute cases, I couldn't find out such changes at first. When I done OCT at the first time, but later on, second time, I have got some changes in that.
If you say like role of spectral domain OCT in blunt ocular trauma patients, we'll expect you to tell us more about the role of that particular instrumentation in the management of these cases. It's not like just saying like there is hyperreflection of the outer retinal layer. These are all very vague conclusions. You should be more. There is no research question in this study framing. Probably the defect is in the study design. There is no research question. You didn't want to do anything. You just said, like, this many patients I saw, and that too, the numbers are very minimal. Very minimal. The numbers are very minimal. And in those cases, you ended up saying, like, this, and all are seen. I don't see anything dramatic also. There is no RP, RIP, no choroidal rupture. Nothing of that kind also is there. And you are just saying like hyperreflective. That kind of studies will not throw any light in either of the disease process or the instrumentation or the way we manage it. So if you design a study, it should be with the research question in mind, saying like, if I do STOCT in all 100 blunt trauma patients which I see this month, how many prognostication I can do pakka? How many cases I can intervene? Like that, you'll have to have a research question. That probably is the defect. That is why your study has come like so. No? So next time when you study, think of a hard question, and from there design the study.
Okay, sir.
Okay, and try to find the answer to that.
Okay, sir. Thank you.
Thank you, Dr. Naina. Next speaker is Dr. Flynn Francis.
Snakebite envenomation is a major neglected tropical disease causing significant global mortality and disability. India accounts for nearly 50% of global snakebite deaths, with the big four snakes responsible for the most severe cases. These are the big four snakes responsible for the severe cases in India. Snake venoms may be hemotoxic, neurotoxic, or cytotoxic, leading to coagulopathy, paralysis, tissue necrosis, and multi-organ dysfunctions. These systemic effects can extend to ocular tissues also. Venoms are rich in protein and peptide toxins that have specificity for a wide range of tissue receptors, making them clinically challenging and scientifically fascinating. Common ocular complications are ptosis, ophthalmoplegia, retinal or vitreous hemorrhage, optic neuritis, uveitis, secondary glaucoma. Many of these complications are potentially reversible if detected early. Early ophthalmic assessment of the envenom patients can help detect reversible complications such as uveitis, glaucoma, optic neuritis, thereby preventing permanent blindness. Aim and objective is to study the occurrence of ophthalmic manifestations in patients bitten by venomous. Materials and method. This is an observational study conducted in Department of Ophthalmology, GUD Mission Medical College, in 43 patients. Patients who present within 72 hours of a venomous snakebite were included in the study. Patients having previous ophthalmoplegia, myasthenia gravis, Guillain-Barré syndrome, patients having hemophilia, sickle cell anemia, or any other bleeding discariasis, non-venomous snakebite were excluded from the study. Method of data collection. All the patients with venomous snakebite were included in the study. Initially, demographics were recorded and detailed history were taken. Then an informed consent is obtained and ophthalmic examination, including anterior and the posterior segment examination, were done at the time of admission, 72 hours, and at the time of discharge. Results: 35 of the 43 patients were males and rest of the 8 were females. Snake type distribution: 21 of the 43 patients were bitten by viper, 8 each by cobra and krait, 6 were unknown bites. Ocular manifestations: ptosis were seen in 4 patients at the time of presentation. Of which after 72 hours, one of the patient got resolved from ptosis and 100% resolution occurs from occurs from ptosis at the time of discharge. Ophthalmoplegia was seen in 5 patients, and 2 patients got resolved from ophthalmoplegia after 72 hours, and 100% resolution from the ophthalmoplegia is seen at the time of discharge. Subconjunctival hemorrhage were seen in 1 patient at the time of discharge, and it persists till the time of discharge. Macular edema was seen in 1 patient at the time of presentation, and it persists till the time of discharge. Ptosis and ophthalmoplegia were seen in cobra bites. Subconjunctival hemorrhage and macular edema were seen in viper bites. This is the OCT macular image showing macular edema in patient bitten by viper. Systemic complications were coagulopathy in 37 patients, neurotoxicity in 33 patients, acute kidney injury in 14 patients. Chi-square test showed no statistically significant association between systemic complications and ocular involvement. Independent deep tests comparing time related variables like time to hospital and time to anti-venom between patients with and without ocular involvement showed no statistically significant differences. No cases of hypema, shallow anterior chamber, vitreous hemorrhage, or macular infection were observed in our study. No cases of RAPD were detected in our study. Visual prognosis was good in all patients with anterior segment involvement with complete resolution. The ophthalmic manifestation in snakebite or iris is a significant cause of morbidity. Ptosis and ophthalmoplegia are well-known manifestations following bite of the cobra. The reason of ophthalmic involvement could be due to the snake venom. Praveen Kumar KV et al. Reported snake bite can result in significant ocular morbidity in majority of the patient, but spontaneous recovery with anti-snake venom, steroids, and conservative management result in good visual prognosis. Okaisu et al. Reported the Viperidae venom causes serious vasospasm, endothelial damage, and increased vascular permeability, and resulted in edema in the ciliary body and the iris. Conclusion: out of the total of 43 patients studied, 6 had ophthalmic manifestations in snakebite. This shows that ophthalmic manifestations can occur in poisonous snakebite. Early detection can prevent development of further complications and improve the final visual outcome. These two are my references.
Doctor, how do you know that patient brought the snakes along with them? That snakes, how do you know they're poisonous or non-poisonous? By seeing the patient.
Patient is showing if any envenomation signs only.
No. How do you patient may not bring the snakes and all after the bite. It's very rare. But how do you know just by seeing the bite site location? Is it possible?
Yes, sir. Will edema tender.
See, multiple punctures non-poisonous. Only 1 or 2 puncture, that is a tooth, that is poisonous. That's all. That's if you see that, easily you can find out. Multiple marks, that is non-poisonous snakes. That you can tell. Okay, and here we got nerve palsy. How many cases out of 6? How many patients had nerve
4
palsy?
patients had ptosis and 5 patients had ophthalmoplegia.
So 6. No.
No, 5 patients had ophthalmoplegia. Both are common.
Then it's what? Cobra or viper?
Total 6 patients. 6 patients had findings. 5 of them had neurological finding, and 1 got hemotoxic finding.
That is, so 5 were by cobras.
Yes.
Only 1 viper.
Right.
Okay, thank you now.
If you show these cases to us, then probably you should also add up like what was the systemic management going on. Was there anti-snake venom given to that person? Was there any other systemic disease which is keeping the patient under ventilator or under something? You'll have to tell that. And in that perspective, divide amongst the neurotoxic and hemotoxic cases and give us a flow. That is a better way to do a cross-sectional study than to do this looks almost anecdotal. You have taken like this many snake bites, you saw 4 ophthalmoplegia, one, this looks almost anecdotal. There is no inferences we create out of it. At best, I think the best inference you can make is cobra bite is dangerous for ophthalmoplegia. Cobra bite makes most ophthalmoplegia. That is
No.
what the inference you have created.
Cobra bite, most of the symptoms got resolved. Hyper bite symptoms are
Yeah, correct. That catch you are bringing, no, that is not reflected in your data. You are bringing it in the inference, but there is no data to show that this is happening. You should also have data to show that whether they had systemic other manifestations other than the ophthalmoplegia, and how many patients had anti-snake venom, how many patients had other management done. These kind of approaches should be needed when you look at a particular toxin which is systemically acting, and eye is just one of the organs. If it is totally eye related, then you can go like this. When it is a systemic issue with eye as one of the manifestations, then you'll have to look at it from that angle. Good, thank you. Dilshad Fatima.
Next speaker is Dr. Dilshad Fatima.
Good morning all. We would like to discuss about our study on demography, clinical picture and etiology of occurred isolated third cranial nerve palsy. Third cranial nerve palsy is an important neuro-ophthalmic disorder with diverse etiologies ranging from benign microvascular ischemia to life-threatening aneurysmal compression. The clinical presentation varies in pupil involvement, ptosis, ocular motility deficits, influencing the diagnostic and imaging decisions. The population-specific data on etiology and demographic pattern remain limited, so our aim was to retrospectively analyze all the cases of occurred isolated third cranial nerve palsy presented to our institute, which is a tertiary eye care center, during the last 15 years, and to describe the demographic characteristics, clinical picture, and the etiologies. For that, we retrospectively analyzed all the electronic medical records of all patients diagnosed with the same between January 2010 and May 2025. For that, we collected the data on demographic details, including age, sex, laterality, clinical presentation, ptosis, diplopia, motility, pupil involvement, and medical history of comorbidities, trauma, surgery, and the investigations done, including neuroimaging, vascular studies, and laboratory investigations. Based on this data, we classified the patients into presumed ischemic, compressive, including aneurysms and masses, traumatic, inflammatory, and others, and also check the treatment offered and recovery status at the 6 months. A total of 63 patients were included. The mean age was 65.8 with a standard deviation of 14.5. The highest incidence was seen in the age group of 61 to 70 years. 39 patients were males with a male to female ratio of 1.6. Right eye involvement was seen in 25 cases and left eye in 26 cases. Bilateral involvement in 2 cases. Among 63 patients, 74 patients had various medical risk factors. Nearly 2/3 of patients had diabetes mellitus. Double vision was the most common presenting complaint, which was complained by 2/3 of the patients, followed by drooping of eyelid. The extraocular motility limitations was universal, and the ptosis was present in 82% of patients, pupillary involvement in 27 cases. Patients with normal MRI brain and orbits and laboratory investigations and having microvascular risk factors were included in presumed ischemic group. 8 patients could not be included because of the lack of follow-up, and so total 55 patients were classified into presumed ischemic, which contained 55%, compressive, aneurysm and tumor 6.3% each, traumatic 9.5%, inflammatory or infective 4.8%, and others 4.8%. This is the pituitary contrast enhanced MRI of a patient with pituitary macroadenoma, and this is the aneurysm of right eye ICA. Among the presumed ischemic group, 33 patients were diabetics. Out of that, more than 2/3 had diabetes for more than 10 years. Within the presumed ischemic group, 10 patients had NPDR and 2 patients had PDR. The pupil involvement was more common in the compressive lesions compared to ischemic causes. Pupil was involved in all traumatic cases and two-thirds of the inflammatory causes. Only 14 patients of ischemic cases came for follow-up after 6 months. Out of that, 57.14% showed complete recovery. In compressive lesions, 2 patients underwent surgical management and recovery documented in 1 case. Age pattern and the male predominance in our study was comparable with the previous studies, and the diplopia and ptosis were the most common presenting problem, with the pupillary involvement seen in more than 25% of patients. In our study, the most common cause was microvascular, followed by trauma, then aneurysm, tumor, then inflammatory or infective, and others. This order was similar to the studies conducted by Fancy et al. And Noorulainen et al. Inflammatory and infective etiologies were less frequent but clinically relevant. The ischemic palsy was strongly associated with systemic vascular comorbidities, particularly diabetes. Nearly two-thirds of diabetic patients in this group had diabetes for more than 10 years, and one-third exhibited diabetic retinopathy. The recovery varied markedly by etiology, and out of followed-up patients, 57.1% showed complete recovery. Recovery in compressive lesions was limited. Strength of our study include relatively large cohort for a single center eye care institute and availability of systemic risk factor data, including duration of diabetes and DR status, and the limitations are retrospective design, incomplete etiological workup, and poor follow-up. So we concluded that ischemic or microvascular disease was the most common etiology, which was strongly linked with long-standing diabetes and other vascular risk factors. The absence of pupillary involvement in 50% of compressive cases highlights the need for neuroimaging in all suspected third nerve palsies. Relatively favorable recovery was noted in ischemic group. The compressive and traumatic palsies demonstrated limited improvement unless treated. So we recommend ensure optimal control of systemic risk factors, especially in elderly patients. Consider early neuroimaging in all third nerve palsy cases to avoid missing vision or life-threatening conditions. Urgently recognize and manage compressive and traumatic third nerve palsies to prevent irreversible deficits. These are our key references. Thank you.
You've done two cases, you have something, surgery was done. What surgery was done those two patients? Those two patients.
Of endovascular coiling. One case of aneurysm, endovascular coiling was done. That was recovered.
Aneurysm of what? Which artery?
Right ICA aneurysm.
What?
Right ICA aneurysm. Internal carotid artery aneurysm.
Right side?
Yes, sir, right.
Internal carotid. Internal carotid artery.
Yes, sir.
Location? Where?
Cavernous segment.
Cavernous segment.
Yes.
Then isolated third nerve palsy.
Yes, sir.
Isolated third nerve palsy, can you get?
The clinical presentation was isolated third nerve palsy.
Then other nerves were involved. Okay, isolated third nerve palsy, normal teaching, of course, you can tell nothing wrong. Okay, but you must tell usually posterior communicating artery we expect. Because it's side by side, it's passing along with the third nerve. Whereas internal carotid artery aneurysm and all, you can expect mainly involvement of cavernous sinus area. You can have other involvement of other nerves also. Very rarely we have got one thing called above the clinoid process. That's called supraclinic aneurysms may produce. Very rare possibly may produce isolated third nerve palsy. Okay.
Okay, sir.
But you have already told, because everyone knows that. What's the difference between surgical problem of third nerve and medical problem of third nerve? Suppose a diabetes produces third nerve problem. Surgery aneurysm producing third nerve. What is the prognostic finding? What will happen? We follow the person.
The medical is recovery is better, and then surgical if intervention is done.
Only one question, no? I don't take it seriously, but the problem is what here? We want to relax and learn something here also. Can you tell me which is called oculomotor nucleus? Which is classically called as oculomotor nucleus. It's oculomotor now, no?
Yes.
You tell me which is called oculomotor nucleus then.
Edinger was.
Huh?
Head injury.
Sure. Are you sure or not?
Yes.
You should only guess.
Yes.
Very good. Okay.
You see, in ischemic causes favorable. The dictum is, if there is a third nerve palsy, because of ischemic cause, it has to recover. Okay, the period is between 1 month to 6 months. If it is not recovering, then the reason is something else. What was the inflammatory cause of third nerve? What was put in your study?
Tolosa syndrome was the
Tolosa. How do you manage that? Where was a lesion, inflammatory lesion? It'll be better if you'll show images, neuro images based, especially so that you'll know what inflammatory cause you'll have come across. What are the other compressive causes of third nerve apart from pituitary tumor and aneurysm what you came across?
hemorrhages.
Does all compressive third nerve, after the reason is addressed, does the recovery is complete?
No,
Rama?
ma'am.
Huh?
No, ma'am.
Why? Start thinking that way. You'll understand the reason, everything much in a better way.
Thank you.
Prospective study is that you already have so much of details, you want to go and glean details out of it or the salient features out of it. I don't know whether you have done anything regarding demographic clinical picture and etiology in optic nerve, in the oculomotor nerve palsies, as you demonstrated. You just bring up one or two scattered findings here and there. Nothing becomes cumulative into some knowledge point, some action point. That is the issue. That is why you yourself said that most of the patients didn't turn for follow-up. You don't have good follow-up of all your patient base. So probably you weren't able to pick up many of the findings which should have been picked up. For example, if you have given an etiology spread nicely, that these are the reasons by which we had, or if you have said like clinical outcomes, this many patients recovered, this many patients had pupillary involvement, this many patients has aberrant innervation, like that, I don't see any tables here. There is no tables to demonstrate the aim of your study, which is to bring out demographic clinical picture and etiology of acquired third nephrosis. You this many RTA, this many tumors, this many. So that kind of correlation is very important in retrospective studies. We do retrospective studies only because we have data already available. We want to take salient points out of that data. Okay. So whenever you are deciding a retrospective study, then you'll have to be more exhaustive and more thorough. If in a prospective study, you might have handicaps. In a retrospective study, most of the times you have good data, and the data analysis should show that in the study. Okay.
Okay.
Thank you.
Thank you.
Your case mostly what? Ischemic type, you told, no? Ischemic
Yes.
nature. Did you follow them up after some time also? You told you are not followed properly. Can you tell me what type of aberrant regeneration these fellows of ischemic type can develop in future? Aberrant regenerations. Suppose diabetic patient is there. He's having a third nerve palsy. In future, what are the various types of aberrant regeneration that fellow can develop diabetic patients? Hello?
Yes.
You don't know? Hey, you know aberrant regeneration or not?
Yes, sir.
You tell me something. You know one thing, your answer should be, sir, ischemic conditions like diabetes, future they will not develop aberrant regenerations. Only traumatic patients, aneurysm patients, they all will develop aberrant regeneration usually. Whereas ischemic problems, normally we don't expect. Understand now? That's why we ask these type of questions. Okay.
Thanks.
Thank you, Dr. Dilshada. Next speaker is Dr. Anaka.
Good afternoon. My topic is ganglion cell complex thinning in hypertensive diabetic patients without retinopathy. I aim of the study to study ganglion cell complex thickness in hypertensive diabetic patients without retinopathy. The materials and methods. The study design was a cross-sectional study and study setting was Department of Ophthalmology, MES Medical College, and the study population was hypertensive diabetic patients without diabetic retinopathy came in ophthalmology outpatient department. The inclusion criteria, that is hypertensive diabetic patients without retinopathic changes, and I excluded the patients having other ocular diseases like glaucoma, patient with history of previous ocular surgeries, trauma, intraocular injections or laser photocoagulation, and ST-OCT reports with poor signal strength less than 6. The sample size was 96 patients. The methodology, full medical and ophthalmology history, visual acuity using Stenel's chart, intraocular pressure with non-contact tonometry, slit lamp examination, dilated fundus examination, and ganglion cell complex thickness measurement using serous STOC. In OCT macula, the ganglion cell complex, that is GCL plus IPL thickness in 6 sectors including superior, superotemporal, supraonasal and inferior, inferotemporal, inferonasal measurement from the elliptical annulus center on the fovea. The measurement is below first percentile of the normative database, which is coded red with minimum GCL IPL is considered as GCC thinning in my study. The data analysis, data entered in Microsoft Excel and analyzed by SPSS software. The mean age of the study was 56 years and the sex distribution, out of 96 patients, majority were male and followed by females, around 46%. The GCC thinning, in right eye there was 39 patients showed GCC thinning and in left eye there were 38 patients showed GCC thinning. There are almost equal GCC thinning noted in right and left eye. Then discussion. Diabetic retinopathy is recognized as the leading cause of visual impairment and blindness, and it is primarily considered as a disorder affecting the retinal microvasculature. Histopathological and OCT based studies showed apoptosis of retinal ganglion cells, reduced synaptic activity and thinning of inner retinal layers even before retinopathy changes occurs. Ganglion cell complex is vulnerable to metabolic stress, chronic hyperglycemia and impaired neurovascularity. The present study reinforces this concept by demonstrating measurable GCC thinning in patients who still have normal fundus on examination. Hypertension appears to exacerbate this process by accelerate neuronal damage through oxidative stress, endothelial dysfunction and impaired retinal perfusion. Conclusion. The present study observed the average age of participant was 56 years. Both the right and left eyes of patients demonstrated a comparable extent of GCC thinning in hypertensive diabetic patients who did not exhibit signs of retinopathy. A significant correlation also identified between degree of GCC thinning with aging. This research offers important insight for individuals with diabetes and hypertension by allowing for the evaluation of GCC thinning, which can enhance patient monitoring practices. The use of SDOCT is anticipated to serve as an effective method for detecting early neurodegenerative changes even before the onset of diabetic retinopathy. The result emphasized the value of incorporating OCT-based GCC analysis into routine evaluation of high-risk diabetic patients. Early identification of neurological alteration provide a critical window for timely systemic optimization and closer ophthalmic surveillance, hence enable more proactive management to preserve long-term visual function. These are my references. Thank you.
How did you find out that reduced synaptic activity, OCT you're told, reduced synaptic activity? So physiology is going on. How do you know that the transmission is not there? How do you know that?
That is based on previous studies of histological and findings, sir. Reduced system.
We are given one inference, synaptic activity is reduced. Then how did you know that synaptic activity is reduced? Yeah, these type of small things, we'll ask in exams. You have to be prepared yourself. Understand?
When you are structuring a study, when you are looking at ganglion cell thinning in diabetic and hypertensive patients without retinopathy, that is your point. Immediately your mind should think whether if the thinning is happening, whether any dysfunction is also happening. That is an immediate corollary, no? Isn't it? So then you'll have to structure something which will test the function also. Or else you will not be able to argue. That is why Dr. VRB is pointing out, if you are saying just an anatomical thinning, it will not have any value unless you corroborate it with some dysfunction. And that, if you have done it, it would have looked a very good study, because all diabetics and hypertensives, we are constantly evaluating them, so we can easily do an ST-OCT on them, and GCC can be picked up. But how much of relevance it will have, how much of inference you make out of that finding is important. The study is not bringing out that. It's just trying to see if you have done like, if the study is like the outer nuclear layer thinning in case of diabetes and hypertension, it would have been same. It wouldn't have been any different from GCC thinning, because you are not getting any functional inference out of it. Okay.
Thank you.
Thank you, Dr. Anaka. Next speaker is Dr. Tamanna Sen.
Yes, you will.
Good afternoon all. My topic is vessel density and nerve fiber layer thickness in mild to moderate primary open angle glaucoma. Coming to the introduction, glaucoma is a leading cause of irreversible blindness. So early diagnosis and close monitoring of glaucoma are important. Mechanical theory explains most of the cases but not all cases. So vascular theory came, which suggests impaired ocular blood flow results in periods of intermittent ischemia resulting in optic nerve damage. OCT angiography is a newer, non-invasive dye-less technique that visualizes retinal and choroidal microvasculature using the dynamic motion of RBCs. Also, radial peripapillary capillary network are specific plexus of capillary bed within the RNFL layer around the optic disc, which is vulnerable to glaucomatous damage, and it constitutes a critical blood source to satisfy nutritional demands of RGC axons. Superficial plexus vessel densities shows better diagnostic accuracy for glaucoma than deep plexus density. Aim of the study was to assess the relationship between peripapillary vessel density, perfusion density as measured by octa, and RNFL thickness in patients with mild to moderate primary open angle glaucoma. To examine the strength of correlation between RNFL loss and reduction in vascular density, and to determine which quadrant exhibited the strongest correlation with each other. Materials and method. It was an observational cross-sectional study conducted between April 2024 to April 2025. Participants included a total of 50 patients of mild to moderate glaucoma. Visual field mean deviation of less than -6 decibel and between -6 decibel to -12 decibel were taken as mild to moderate glaucoma based on Hoda-Parrish-Anderson criteria by HFA single field analysis. Inclusion criteria include age more than 18 years, open angle on gonioscopic examination, best corrected visual acuity of 612 or better. Exclusion criteria include media opacities that prevented good quality opta images, age less than 18 years or more than 90 years, previous diagnosis of optic nerve and retinal vascular pathology, high myopia, non-glaucomatous optic neuropathy, all forms of secondary open angle glaucoma, and opta images with a signal strength of less than 7. Coming to the methodology, basic demographic details and ophthalmologic investigation, including best corrected visual acuity, IOP, axial length, and visual field were recorded. Spectral domain OCT images were obtained from Cyrus ST OCT. RNFL thickness are measured using the 200 × 200 optic disc cube scanning protocol. Octa was performed simultaneously using the same device running the Angioplex software. Vessel density and perfusion density were automatically measured. Outcome measures. Octa results for the optic nerve head measured vessel density and perfusion density of full, outer, inner disc and quadrant by superior, inferior, nasal and temporal vessel and perfusion density. RNFL thickness measurements for the peripapillary zone were recorded in superior, inferior, nasal and temporal quadrants. Coming to the results, most of them were within the age group of 61 to 70 years, and 60% of them were females and 40% were males. And this is a table showing the correlation between RNFL thickness and vessel density. Here we can see that the average RNFL thickness showed moderate positive correlation with the full and inner vessel density, and among the quadrants, superior and inferior RNFL thickness showed moderate positive correlation with the full and inner vessel density. And this is the table showing relation between RNFL thickness and perfusion density. Here also average RNFL thickness show significant correlation with perfusion density, especially full and inner, and superior and inferior quadrants also show significant correlation with the perfusion density. And this is the heat map figure showing the correlation between quadrant RNFL and vessel density. Here we can see that the superior RNFL thickness showed the most significant correlation with the corresponding superior vessel density. Inferior RNFL and nasal RNFL are also significant, but superior was the most significant. And this is a heat map figure showing the relation between quadrant RNFL and perfusion density. Here also we can see that the superior RNFL and superior perfusion density were most correlated. Coming to the discussion, the study showed a strong topographic link between RNFL thinning, that is structural loss, and reduced peripapillary capillary density, supporting the role of vascular factors in glaucoma, which was similar to study by Bill et al. And inner ring vessel density and perfusion density showed the strongest correlation, indicating microvasculature near the optic nerve head closely reflects the axonal health. Also, superior RNFL thickness exhibited the strongest correlation observed in the entire quadrant-specific analysis, and superior and inferior regions, which are the most vulnerable to glaucomatous structural damage, are also where the relationship between structural loss and vascular compromise is most apparent. The temporal quadrant, normally the thinnest, remains relatively preserved. So coming to conclusion, in mild to moderate primary open-angle glaucoma, there is a significant topographically specific correlation between RNFL thinning and reduced peripapillary microvasculature. All these findings support the hypothesis that vascular compromise is intrinsically linked to neurodegeneration in glaucoma and highlight the diagnostic value of quadrant-specific octa analysis. These are my references.
Doctor, that is, we have got slides, PowerPoint slides preparations also. You have got 25 marks. From here, and I am not able to see the slides properly, and all the letters are very small. So now, that's why slide preparation also you must make it in such a way it should be attractive.
Yes.
Okay, so that you can score more marks.
Okay.
You understood?
Okay, sir.
Okay, thank you.
Mm. Mm. Mild to moderate. Mm. 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 No. Okay, sir.
Practically, how can we make a difference in our clinical care?
We can, since a significant amount of RNFL loss can occur before the appearance of visual field changes and clinical changes, we can use octa as a part of routine investigation.
Are we too expensive?
Mm.
Really, if it is really mandatory, like identifying the correct clinical cases where this will make a difference. Those are the patients you should subject them to OCTA. But practically getting it done on everybody with no visual field effects, nothing, we need to think about it.
Mhm. Thank you.
Thank you, Dr. Tamanna Salim. Next speaker is Dr. Fatima Muhammad.
Good afternoon, all. My topic is evaluation of visual outcomes following implantation of monofocal plus IOL, extended depth of focus IOL, and trifocal IOLs. Cataract surgery has evolved from a rehabilitative to a refractive procedure aiming for spectacle independence. Intraocular lens selection plays a crucial role in achieving optimal postoperative visual quality. Conventional monofocals correct distant vision but require spectacle for near task. Newer IOLs like monofocal plus, add-off, trifocal try to balance between range of vision and visual quality. The various IOL available are monofocal, monofocal plus, add-off, and multifocal. Monofocal plus lens use a modified aspheric design to slightly enhance the intermediate vision, mainly for computer works compared to traditional monofocals. Add-off IOLs are defined by the FDA as lenses that provide Snellen visual acuity to within one letter of that provided by a monofocal IOL, a depth of field that is at least 0.50 diopter greater than a monofocal. Depending on the pupil size, most monofocals provide 0.75 to 0.1 diopter of depth of field. An additional 0.5 diopter depth of field increases that from 1.25 to 1.5 diopter. Aim of my study is to evaluate post-operative visual outcomes following cataract surgery using monofocal plus, add-off, and multifocal IOLs, and to analyze the patient satisfaction and spectacle independence level. Materials and method. Visual acuity is measured using Snellen's chart converted to logMorpho analysis. My study is a prospective observational study conducted at a tertiary eye care hospital. 70 patients in total who underwent phaco were selected. Preoperative and postoperative visual assessment performed at 1 month follow-up. Visual acuity was initially measured using Snellen's chart and later was converted to logMorpho analysis. Inclusion criteria: age more than 40 years, age-related cataract, no prior ocular surgery, absence of corneal, macular or optic nerve pathology. Exclusion criteria: macular disease, glaucoma with field loss, ocular surface disease affecting visual quality. IOLs used in my study: monofocal plus lens, Eyhance and Clarion, add-off lenses Purity and Vivity, and multifocal Synergy. Results: uncorrected visual acuity of 6.6 to 6.9 were achieved by 87.5% of Eyhance users, 95.7% of Clarion users, 100% each of Vivity and Purity users. Distance corrected intermediate visual acuity of 79.2% was achieved by Eyhance users, 82.03% by Clarion users, 100% each by Vivity and Purity users. Distance corrected near visual acuity of N6 to N8 were achieved by 73.1% of Eyhance users, 75% of Clarion users, 100% each of Vivity and Purity users. In multifocal IOL, all uncorrected visual acuity of 6.6 to 6.9, distant corrected intermediate visual acuity, and distant corrected near visual acuity was achieved by all 100% of MF-IOL users. All IOL groups showed significant postoperative improvement in distant visual acuity. In addition to distant vision, monofocal offered functional intermediate vision. Add-off lenses offered intermediate and functional near vision. Multifocal offered continuous range of vision with good near, intermediate, and distant vision. High spectacle independence rate noted for distance and intermediate vision. Low levels of visual disturbances reported, especially with add-off lens users. Add-off lenses provide a single elongated focal point that seamlessly improve depth of focus and range of vision. This emerging technology is ideal for patients who do not want their functional vision to be compromised as they shift focus across distances. Modern presbyopia correcting IOLs deliver excellent functional vision post-surgery. Monofocal plus provides a conservative enhancement of intermediate vision with minimal side effect, often a safe and economic upgrade from traditional monofocals. Add-off lenses bridge the gap between monofocal and multifocal lenses, offering extended range without significant dysphotopsia. Trifocal lenses gives the best near and intermediate vision. Increased photic phenomenon was reported by 50% of patients. So modern IOL technology allows customized refractive outcomes post-cataract surgery. No single IOL fits all. Personalized selection ensures optimal satisfaction. Monofocal plus reduce spectacle dependence without producing halos or glare. Add-off lenses minimize dysphotopsia while improving intermediate vision. Multifocal or trifocal IOLs provide maximum spectacle independence with potential for halos. Patient education and expectation management are key to successful outcomes. These are my references. Thank you. Okay, sir. Mm. Yes, yes, sir. Yes. Yes, yes, sir. Always same by same surgeons. Okay, okay, sir. Okay, sir. Okay, sir. Thank you, sir.
Are you awake? No,
Ye- Yes, sir.
not sleeping.
Me?
It's not for fun.
No, no, sir.
Alert.
Yes.
A few questions only, hello, because we are preparing for exams. Unrelated to this, of course, topic is same IOL. Can you tell me who was the first person who put IOL?
Sir Harold Priestley.
Harold
Sir
Priestley.
Harold,
Priestley.
Harold,
Maybe Idli. You told Idli.
Alice, sir.
Huh?
Har-
Idli what?
Harold Priestley.
Ridley. Suppose you have
Ridley.
forgotten, we'll ask in exams. Morning cab breakfast you had. If you tell Idli, answer is over.
No, sir. Harold
Ridley.
Ridley.
Very good. On which date? At which hospital? In UK where?
Sir,
On
in 1949.
49th month, date. Then again, hello, became, it's a failure. Then again he did on February 1950. These dates and all you're supposed to know because he has told so many multifocal, everything has evolved from there only. The starting point was that.
Yes.
How to follow? You know how that fellow got the idea?
Sir, he was one pilot, he was traveling in a flight and some bird crashed and
Bird,
accident.
Second World War problem occurred. Hello, so many fighter pilots had injury and then all the windshield, no? You entered
It
their eye
broke
and
and
becomes inert. Bird, from where the bird came? But this fellow, he had the idea, of course. He came to conclusion that means what? This material is inert inside the eye, that's all. But how that fellow got the idea of putting IOL inside?
That object was
It was
inert.
lying inside, man, without any problem. So that's why he came to conclusion, oh, this is PMMS, whatever thing acrylic is okay. Inside the eye is inert. Before that only so many fellows tried, you know, that they were used to implant, ocular implants and all acrylic implants. So many fellows they did. You have heard about his Stellar surgeon?
No.
Stellar was a surgeon, hello. He wrote a book also, ophthalmic surgery.
Okay, sir.
That fellow implanted acrylic implants and all those days itself. But IOL, how this doctor got the idea of something, somebody has to tell you do this. Can tell me who was the first person who told that readily to do? You don't know.
No, sir.
Medical student, man, third year medical student. That fellow told, sir, you have removed something from inside. Why didn't you put inside something? So he got the idea. These are all common Viva questions. If you answer all these things, you'll get distinction.
Okay, sir.
You will get pass, agreed. Hello. Idea is what? To get distinctions. Understand?
Yes, sir.
Thank you.
Thank you, sir. Sir. Yes. Okay, sir. Thank you, sir.
Thank you, Dr. Fatima. Next is Dr. Afia.
Good afternoon. Peripapillary retinal nerve fiber layer thickness by OCT in myopia. Myopia is most common form of refractive error causing ocular mobility worldwide. It is well recognized that myopic eyes are more susceptible to glaucoma. Why this study? Myopia can obstruct the results of structural and functional tests used to diagnose glaucoma. So this study aims to achieve this understanding by determining the critical limit to which retinal nerve fiber layer thickness is affected by myopia, and this will help to differentiate the retinal nerve fiber layer changes in myopia from that caused by glaucoma. Objective of my study is to assess the peripapillary retinal nerve fiber layer thickness in myopia severity group using OCT. Methodology, study design is a hospital-based cross-sectional study. Duration is 1.5 years. Sampling method is non-probability sampling. Study population is patient attending the ophthalmology OPD at Government TD Medical College, Alappuzha. Sample size is 204 eyes. Inclusion criteria is spherical equivalent more than or equal to 0.5 diopter in myopia group. Age group between 18 to 40 years. Exclusion criteria is peripapillary atrophy extending more than 1.7 millimeter from the center of the optic disc, which interfered with optic disc cube measurement. Prior ocular or refractive surgery. Patients suffer from any ocular or neurological disease that causes thinning of RNFL, and patients suffer from any pathological ocular or neurological condition that affect their vision. Study variables are visual acuity, fundus examination by 90D, automated refraction, OCT RNFL assessment by Cirrus SD-OCT, axial length by A-scan. Results of the study. Mean in my study population, mean age group is 27.5 years, and the 47.5 are females and 52.5 are males. By comparing the relationship between the severity of the myopia and RNFL thickness, average RNFL thickness is decreased from 104.1 micrometer in mild myopia to 76.3 micrometer in severe myopia. There is significant reduction where observed in all quadrant, which is more pronounced in temporal and inferior quadrant. Average RNFL thickness below 76 micrometer or a temporal RNFL thickness below 55 micrometer, which serves as a critical threshold to differentiate between myopic changes and the glaucomatous damages. Then by comparing the correlation between the axial length and the average RNFL, there is a strong inverse correlation was identified between axial length and the RNFL thickness. Comparing the correlation between disc area and the average RNFL, disc area enlargement correlate negatively with RNFL thickness. In my study, there is no statistically significant correlation was found between age and the RNFL thickness. Conclusion of my study, There is significant relationship between myopia severity and RNFL thickness, and RNFL thinning progresses with increasing myopia, especially in inferior and temporal quadrant. An average RNFL thickness below 76 micrometer or temporal RNFL thickness below 55 micrometer, which serves as a critical threshold to differentiate between myopic change and glaucomatous damage. Axial elongation emerges as a key factor influencing the RNFL thinning, reinforcing the biomechanical effect of myopia on retinal structure. Changes in optic disc morphology such as disc area enlargement are significantly associated with reduced RNFL thickness, emphasizing the need to consider the optic disc size when interpreting OCT measurement in myopic eyes. There is a weak correlation between age and the RNFL thickness within the study age group, suggests that myopia-driven structural changes are primarily due to refractive error and the axial length rather than age. Limitation of my study: there is a relatively small sample size, and the study only include participants aged 18 to 40 years, excluding the children and the older adults, which are also significantly affected by the myopia. Patients with peripapillary atrophy beyond 1.7 mm or prior ocular surgeries were excluded, potentially skewing the results towards the healthier myopic eyes. RNFL thinning is also observed in glaucoma, and glaucoma cannot be excluded in this study population based on HFA result. And RNFL thinning measurement might have been affected by the artifacts or calibration differences in high myopic eyes with tilted or deformed optic disc. And this study does not exclude other retinal layers such as ganglion cell layer, which are also affected by the myopia and could provide a complementary diagnostic insight. And this is the cross-sectional nature that prevents the longitudinal analysis, making it impossible to track RNFL changes over time or with progression of myopia. These are the references.
Bringing in a disease, a condition like myopia causing RNFL defects, RNFL thinning, then it's a very good opportunity for you to compare between eyes. No, you can say in a myopia person of 7.5 in right eye, 7.5 in left eye, this much is the RNFL thickness. Or in certain patients where there is anisometropia, you can prove that one eye which at 7.5 had this much of thickness, one eye which is minus 0.5 had this much of thickness. So those things you are not exploring. That basically is very important when you're trying to put blame a condition on an anatomical eventuality. Yeah? Or else this will stand alone as something very anecdotal. You don't have corroboration here. You don't have proof that this exactly is the operant factor for this condition, this eventuality. Okay.
Just like Sir said, in myopia, the disc can be tilted, right? So of course you're going to have temporal layers are going to be thinned out. That will show thinning on the GCC. That does not mean the vision or visual field defects are going to be there. So always correlate. Again, a person who's myopic can go ahead and develop a neurological disorder. So you need to follow up. And as Sir said, just that isolated with OCT, progression myopia, how you're going to help the patient, I'm not very sure about it.
Something, just I'll ask you one question only again. It's just it's a sort of conveying our, this should learn something from here also. You are told myopia. Can you tell me the meaning of the word myopia? You have presented so much OCT, ganglion, so many things you've told. Myopia, myopia, myopia. What do you, I'm not asking the definition of myopia. What is the word, literal meaning of the word myopia? You are myope, no? You are myope. What's your power? Minus?
Minus
2. 2. You remove the glass now. Now look at us. Can you see? Suppose you want to see me without putting glass. Hello. Imagine now. You will do what? You will do what? Hey, don't put the glass, man. You will not, don't come towards us. You have to be there and try to see you. How to see? What will you do? Hello? Huh? You tell the answer now. Myopia means to close. Hello, to shut the eyes, shut the lids. That's the meaning of the word myopia, to shut or to close. Understand now? Because you are wearing glass, no. They said all tell us to let me see whether this girl is telling the answer or not. Let me ask you. You have to be very careful. Hello. Basic should be strong. Okay. Thank you.
Thank you, Dr. Afia. Next speaker is Dr. Sana Fatima.
Good afternoon, all. So my free paper title is Recurrent Corneal Erosion Syndrome, the role of ASOCT epithelial mapping. So RCE is a condition which is characterized by abnormal epithelial adhesion to the Bowman's layer, causing spontaneous episodes of epithelial breakdown, causing the patient to have sudden onset ocular pain, photophobia, blurred vision on awakening. So it's a condition primarily diagnosed through slit lamp examination, and despite advances in understanding the pathogenesis, recurrences remain unpredictable, and the follow-ups often rely solely on clinical examination. So here, our aim is to determine the role of ASOCT epithelial mapping in delineating the areas of epithelial instabilities across the acute and quiescent phases. So materials and method, it's a prospective observational study which has got IRB approval carried out during the period of December 2022 to November 2024. And we have included all the patients with symptoms suggestive of RCs, excluding those with corneal scars, infection, dystrophies, and surgeries. So at presentation, the patients were subjected to slit lamp examination, fluorescent staining, and ASOCT epithelial mapping. Then they were started on uniform medications, which included lubricants, sodium chloride ointment, and drops. And they were asked to follow up after 2 weeks to ensure healing of the epithelial erosion. And the following were repeated in the follow-up visit also. So this is a case in which a patient presented to us in the acute stage, that's in the primary visit. So here the slit lamp examination shows areas of epithelial erosion, and the same day ASOCT epithelial map shows red regions which are termed as hotspot, which are actually the epithelial thickening, and these hotspot are corresponding to the area of epithelial irregularity. So the same patient, when he came after 2 weeks of starting medication, we can see a healed epithelial erosion in slit lamp examination, and the ASOCT epithelial map repeated show a persisting hotspot. So coming to the result, we had a total 40 patients enrolled, out of which 19 came for the follow-up visit. The mean age of the sample being 37.5, and predominantly they were females. So when we compared the slit lamp examination, the epithelial erosion present in the primary visit were 84.2%, which has reduced to 18.75% in the follow-up visit. That is, 81.25 of the patients had their epithelial erosions healed on slit lamp examination in the follow-up visit. So when we analyze the hotspot in primary and follow-up visit, 94.7% of the patient had hotspot in the primary visit, whereas in the second visit also 73.7% had that persisting hotspot, despite most of them had their cornea clinically clear. And also we have analyzed the hotspot in terms of correspondence in size and site in first and follow-up visit, which shows 92% of the hotspot in second visit corresponded in size and location to the initial mapping finding, even though the epithelial erosion have healed. So as we mentioned, it's a primarily clinically diagnosed condition through slit lamp examination, and identifying these areas of epithelial irregularity using slit lamp examination alone is challenging in quiescent stages. And it was the work of Oikonomakis et al. That highlighted ASOCT epithelial mapping as a promising tool for detecting the areas of epithelial irregularities and potentially guiding targeted interventions. So our study strengthens this finding. That is, most of the patient had their epithelial erosion healed on slit lamp examination, but 73.6% had persisting hotspot on ASOCT epithelial map in the follow-up visit, and most of them were corresponding in size and location. And these all findings suggest that there is a persistent subclinical adhesion abnormalities despite apparent healing of the cornea. So the limitations were we had a small sample size and the follow-up duration were shorter, and only 9 mm of the cornea was imaged in anterior segment is OCT epithelial mapping, and RCs beyond this area was difficult to map. So the highlights are it's a prospective study and the first study to demonstrate a method for identifying the areas of abnormal epithelial adherence in patients presenting without epithelial erosion. So we conclude that ASOCT epithelial mapping effectively localizes the area of abnormal epithelial adherence in recurrent corneal erosion syndrome, thus identifying the areas prone to erosion even in cases of a clinically resolved RCEs and in microform erosions. Thus, it can be a valuable adjunct to slit lamp examination in the diagnosis as well as the management. These are my references. Thank you.
Trying to say that it's a hot spot, then you'll have to validate saying that this is first day healing, this third day healing, this seventh day healing. Yes or no?
Sir.
You yourself are saying that subepithelial adherence hasn't happened, epithelium is covered up. That is how epithelial turnover happens.
Yes.
We all accept it as a science. You are making it as if appear as if it's a flaw. It's not a flaw. That is how it will happen. So that we all understand. Should you have given the time frame from when the erosion happened to when the healing actually becomes permanent, that would have thrown some light. Just saying that we'll do ASOCT and pick up hotspots doesn't matter, doesn't bring us. So what do? We'll presume. The question is like vice versa. You, in a recurrent corneal erosion, patient comes to you, you do a ASOCT, patient has no complaint, patient's slit lamp is perfectly normal, staining is 0, and you do ASOCT, you pick up 5 hotspots. What do you do?
Like if the patient is symptomatic, still
No
that
symptoms.
no symptoms.
You
Okay.
yourself said no symptoms. What will you do?
So we can actually call them back. If they are symptoms only, we had to start them on any medication. So we can ask them to follow up after a duration of 2 weeks at least. That if there is any.
This decision, a general ophthalmologist himself will make. No. Why should you have an ASOCT and a corneal surgeon looking at that and telling the same? Whatever you said now, a general ophthalmologist will say. You understand?
Yes, sir.
So the weight of an investigation is in the validation of the result and the eventual output from that which translates as interference or intervention in that particular case. Here it doesn't come. It doesn't come. If you had said, like, if there is hot spots, then you'll have to increase lubricants, you have to increase something of that kind, then I would have taken it. There is nothing what you are trying to say. You're just trying to say that incidentally hot spots are revealed. I am saying that they will be revealed. 100% they will be revealed. Okay.
Okay, sir.
So there is no correlation here. So that's why I said when you are designing a study, that initial question should be strong, or else the inferences will come, but they will not be valid.
Okay, sir.
These persistent hotspots patients had any history of diabetes and all? Did you
Systemic.
find out? Because you
No.
told now hotspot is still there.
Yes, sir.
Why don't you put them for this? Just investigation for in academic interest.
We'll try to do
Because
it, sir.
diabetic patients are notorious for having recurrent erosions.
Okay.
So naturally, if you see the hotspots and all, why can't you put them for blood sugar and all at least? Or at least history of diabetes was there in those patients.
We haven't looked into any systemic correlation, sir. But any ocular infections or anything they had, we have excluded them. But systemic correlation, we haven't done yet. Anything. We haven't analyzed.
Thank you, Dr. Sana. Next speaker is Dr. Anushri S. Nair.
Good afternoon, everyone. My paper is on the outcome of corneal compression sutures for acute hydrops in keratoconus. Acute hydrops is a debilitating complication of corneal ectatic disorders characterized by corneal edema and symptoms like pain, photophobia, and defective vision. The conservative management of acute corneal hydrops takes a long time for resolution, and thus this may affect the patient's quality of life. When surgical modalities like compression sutures were combined with intracameral injection of air or gas tamponade is done, this helps in quicker resolution of edema and symptoms. The internal tamponade is provided by air or gas, as well as the external tamponade is provided by the compression sutures. Thus, the objective of my study is to describe the outcome of corneal compression sutures in hastening the resolution of corneal edema due to acute eye drops in keratoconus. Methodology. This was a retrospective case analysis, which included the electronic medical records of 6 patients who developed acute eye drops secondary to keratoconus and presented to our tertiary care center between September 2022 and May 2025. Preoperatively, the corneal edema was evaluated using slit lamp photography images, measuring the uncorrected and best corrected visual acuity of the patients, and the central corneal thickness in microns was measured using anterior segment optical coherence tomography. Post-procedure, the improvement in edema was evaluated using the same parameters, as well as the time taken for edema resolution and symptomatic improvement was also measured. All the patients were initially treated with conservative methods, following which no satisfactory treatment outcome was observed, and then they were all taken for compression sutures. This was the surgical technique. Through the paracentesis, air is injected into the anterior chamber to delineate the Descemet's membrane tear, and perpendicular to the tear, partial thickness corneal compression sutures were taken. On tightening the sutures, on-table intraoperative egress of fluid was noted, and then it was marked. All the sutures were made tight, and then all the sutures were buried. Again, air was injected into the AC, kept for 20 minutes. Minimal air was left behind, and then BCL was placed. Results. The mean time for symptomatic relief and the mean time taken for edema resolution was found to be 1 day, and mean lines of improvement in best corrected visual acuity in a mean time period of 1 month post-operative was found to be 1 line in logMAR scale. The mean time follow-up for the patients were 1.5 months. Sutures were removed in all the patients as and when it got loosened. Results. The mean uncorrected visual acuity improved from 2.083 logMAR to 1.317, and best corrected visual acuity improved from 2.083 to 1.117. Mean central corneal thickness in microns measured using ASO-CT improved from 655.5 microns to 414.67 microns. These are a few clinical photographs. The first preoperative ASO-CT image shows significant corneal edema and intrastromal cleft, which can be seen reduced in the post-operative day 5 image. Below is a slit lamp photography image of the same patient, one of our patients under study. Discussion. Acute eye drops is a self-limiting disorder which in many cases resolves by observation alone, but this, as well as the traditional methods, takes a long time for resolution, and this affects the patient's quality of life badly. With the application of corneal compression sutures combined with intracameral air injection, faster resolution of corneal edema is observed, and also early quicker symptomatic relief is also observed. Probably the complications of long-standing edema like corneal neovascularization as well as scarring might also be reduced, and this helps in early visual rehabilitation and provides better quality of life for the patients. A few studies have been done previously on the outcome of commonly used procedures for acute eye drops management, and out of them, in a study by Sunita Chaurase et al. In 2022, using modified partial thickness compression sutures and minimal intracameral air injection, the mean time for resolution was found to be 1 day, and no complications were found. Similarly, in our study, using the same intervention, the mean time taken for resolution of edema and symptoms was also found to be 1 day, and no complications were found. Residual corneal scarring was invariably present in all the patients, and they were all visually rehabilitated either with spectacles or scleral contact lenses or penetrating keratoplasty. Limitations of our study. This is a retrospective case study, and also the sample size is small. Thus, we can conclude that corneal compression sutures are a safe and effective modality to treat acute eye drops and helps in early resolution of corneal edema, and thus this can widely be employed with a good surgical practice and expertise. These are my references, and thank you.
Your outcome is a dictum.
Sir.
We have already accepted that.
Yes, sir.
We don't need a study to come and prove it. I would have been happy if you have done that study with a balanced approach. Like the downside you are not telling. You are saying eye drops gets things better.
Yes, sir.
But I'll tell you what all it will get bad. the compression sutures might worsen the astigmatism.
Yes.
Compression sutures might create more suture-related issues in that already sick cornea. Certain times a compression suture might come to a level where you can't even put a PCL over it. Okay, so those downsides also you should say,
Yes, sir.
and then say it's a valid approach. You should never say none. Your slide shows complications none.
Yes, sir.
It's as if like you expected endophthalmitis in all these cases and none happened. That kind of result you should not bring out. Even the nuanced ones, even the layered ones, you should bring out.
Okay, sir.
Okay.
For any of these patients, did you go ahead and remove these sutures?
Yes, ma'am. All
What
the
was the time
sutures were
duration?
on loosening during follow-up visits. It was all removed. And approximately in a duration of 1.5 months, all the patients had their sutures removed.
In case there's a recurrence of eye drops, do you again place the sutures?
In one of our patients, we had to do the surgery twice.
And what was the suture material used?
Tensor nylon, ma'am.
Tensor nylon,
Yes, sir.
not silk.
No, sir. It was tensor nylon, sir.
Needle.
Needle size, I don't precisely remember, sir. I don't-
Needle you should know, no? 3/4 of a cycle or 1/3 or something, you know, you got. Spatulated needle, micro point.
I
That
don't.
will ask you in exams. Please remember.
Sure, sir.
If you see a tell 10 nylon, no, okay, will not leave you.
Okay, sir.
You must tell what's the curvature of the needle,
Okay, sir.
3/8 of a circle, something you must tell.
Uh,
And spatulated micro point. Then only can pass through the cornea, man.
okay, sir.
You cannot use a round body needle, you know that?
I'll see to that, sir.
Round body needles are for your intestines and all, mucous membranes. Have you ever tried a round body needle to put a corneal suture?
No, sir.
Go and try. We'll see.
Wait.
Okay, last question. Suppose silk suture is there.
Yes, sir.
This is for exam purpose. And nylon suture is there. You have put a knot.
Yes, sir. Okay.
After suturing, you have to put a knot, no?
Yes, sir.
You have to cut the suture, in which case near the knot, in which case away from knot.
For external procedures,
Then you tell me silk or nylon, that's all. Silk suture I put
yes, sir.
near the close the knot.
Okay, sir.
Or nylon suture I have to close the knot. That's all.
Nylon should be cut closer to the.
So that it can get released and everything can open. Understand? Please remember, nylon to be left something.
Sir.
Silk can be cut very close.
Okay,
You know one word is called memory. Have you heard about it? Sutures have got some memory or something.
Yes, sir.
Remember like this.
Yes, sir.
The silk has got very good memory. It will not leave its friend, other end. Whereas nylon can easily throw it out.
Okay, sir.
That's called memory of the suture. Okay.
Sir.
There is also Viva type of questions.
Okay,
That's
sir.
why I'm asking. Okay, thank you.
Thank you, sir.
Dr. Anushri. Next speaker is Dr. Anjana.
So, good afternoon, all. So, our study is on factors affecting the non-adherence to anti-VEGF therapy in patients with diabetic macular edema. So, as we all know, diabetic macular edema is the accumulation of excess fluid in the extracellular space within the retina in the macular area. And anti-VEGF therapy has emerged as a standard treatment for diabetic macular edema. But despite proven efficacy, poor treatment adherence remains a significant challenge affecting visual outcomes in DME patients. So, going to the administration protocols. So, we will be having an initial protocol and a follow-up protocol for the patients. In initial protocol, it may be either a loading dose protocol or a PRN, that is Prorineta. In loading dose protocols, we will be giving an initial 3 monthly injections to all. And in Prorineta, we will be giving injections according to the clinical disease activity of the patient. In follow-up protocol also, we will be having either PRN or a treat and extend protocol. PRN we have already told. And in treat and extend protocol, we will be giving initial monthly injections till no disease activity is seen, and injections will be given at every visit but with increasing follow-up intervals.
So the aim of our study was to evaluate the causes of poor compliance with anti-VEGF therapy in DME patients and also to assess the influence of the various dosing regimens and the type of anti-VEGF used in relation to the compliance issues. So we have studied 160 patients who was diagnosed with DME with clinical findings OCT or FA and were initiated on anti-VEGF therapy. And their demographic details, eye status, treatment strategy, anti-VEGF use, follow-up details were collected. And the patients were followed up for 12 months, and those who failed to follow up were contacted by phone to determine the reasons for non-compliance. And in our study, we have defined non-adherence as missing more than or equal to 2 treatment or monitoring visits over 12 months, with a visit considered missed if it exceeded more than 1 week from the recommended date. So coming to the results. So in our study, we have found that more than half of the patients, that is around 55% of the patients, failed to maintain adequate compliance with their prescribed anti-VEGF treatment regimen. And the major reasons came out to be other systemic comorbidities, which accounted for around 25%, closely followed by non-affordability of accounting to 21.6%, and no improvement in vision accounting to 18.2%, and no visual complaints also came out to be a main reason, around accounting for 10.2%. And other secondary reasons included health insurance related issues, the shift of residence of the patients or lack of bystanders, transport issues, etc. So going to the age distribution and age-related adherence pattern, when we compare the age pattern, there is a trend towards decreasing adherence with advancing age. And when we compare the gender-based distribution, there was a balanced distribution in our study between males and females, and male patients demonstrated better adherence rate when compared to female patients, which was approaching significance. And when we patient categorize, we have categorized the patients in our study into old and new patients. And old patients mean those who had already previously had received a treatment and they were familiar with the treatment strategy. And new patients, they were treatment naive. And when we analyze their adherence, old patients with prior treatment experience had demonstrated a significantly better adherence rate when compared to new patients. And anti-VEGF medication distribution in our study was ranibizumab was the mostly prescribed one in our study, followed by aflibercept and brolucizumab. And when we compare the adherence based on the anti-VEGF type use, there was no much statistical significance. Ranibizumab users showed a higher non-adherence rate, maybe because they were prescribed more. And brolucizumab users were very small in number, but they showed 100% adherence, though was a small sample size. And when we compare the initial treatment protocol and their adherence basis, in our study, the majority of the patients were under PRN protocol in the initial strategy, and only around 4% received loading dose protocol. And all patients who received the loading dose protocols were found out to be non-adherent in our study. So coming to the treatment switching patterns, in our study, majority around 92% were continued with the same anti-VEGF agent, and only around 10% needed switch. And the main agents which were switched were to Azudex, dexamethasone implant, or an aflibercept. And when we compare the adherence between the patients who were switched and non-switched, the patients who underwent treatment switching showed remarkably better adherence rate when compared to the patient who didn't require a switch. So this is a comparison of the number of injections the patient took before becoming non-adherent. Here we can see an early discontinuation pattern. That is around 71.6% of the non-adherent patients discontinued within the first 3 follow-up injections. So our study was a prospective study which was conducted in 160 patients with a high non-adherence rate of 55%, and the main reasons for non-adherence been other comorbidities, non-affordability, and no improvement in vision. Another similar study by Bolhesen et al., which is also a retrospective study, showed a similar non-adherence rate of around 64%, with reasons being the cost problems, planned number of injections. And Indian study by Aditya Kelkar et al., which is also a retrospective study, which showed a similar non-adherence rate of around 52%, with higher reason being the non-affordability. To conclude, we had a high non-adherence rate among the patients with an early discontinuation pattern with multifactorial causes for the non-adherence, with significant associations in patients who are previously treated showed a good adherence. Treatment switching patients also showed a good adherence. Loading dose protocols patients were very poor with the adherence, and advancing age and female gender were also determinants for non-adherence. So our take-home message may be we should be, a healthcare system should minimize the financial barriers through, and should provide good patient education and should provide a coordinated care approach with flexible treatment protocols for better anti-VEGF adherence. These are my references. Thank you.
Care tried all that which you have suggested. All your recommendations, use Medicare said. It in fact provided to all its citizens. Any number of injections you can give, whichever injection you want you can give, and yet it went down the drain. In fact, then only it commissioned the CAT trial. Go find out, go read about the CAT trial, and try to understand what made US to do the CAT trial. Okay. So those recommendations which you have brought, we don't concur with, because when there is no, you yourself saying no visual improvement, economical difficulty because of what is the cost of brolucizumab?
Brolucizumab around around 40, sir. 30 to 40. Yeah.
So these were the factors which affected patients' non-adherence. They didn't want to stay sick. They wanted cure, but you created hindrance. It's not the patient who created hindrance. In fact, your treatment protocol created hindrance because it was a bit beyond his reach, and that is what happened. Had you switched to bevacizumab in these cases?
No, sir.
Had you switched to bevacizumab in these cases, when there was financial difficulties and non-adherence, when you are given an option 2 or a fallback to these patients, I am sure they would have taken and they would have got better. Point number 1. Point number 2, when you are saying non-adherence is a big hindrance, then you will have to have a RCT style study where you prove that adherence always creates benefits. Your study doesn't show that. Your study doesn't say how much of your study population exactly obeyed whatever you said and ended up with good vision. I'm sure there is no concrete outcomes in that side also. So when you are claiming that non-adherence creates difficulties, then obviously you'll have to, the vice versa should be true, no? You should prove that adherence creates good benefits. You aren't even proving that. And second, these trade names tend to avoid. Whenever you are making studies, keep generic molecular names into that study and don't keep trade names.
Thank you, Dr. Anjana. Next speaker is Dr. Pooja.
Good afternoon all. Our study is on analysis of OCT RNFL and minimum rim width in myopic tilted disc and suspicious curve. Myopia can cause structural changes in eyes which make them more susceptible to axonal loss and can cause glaucomatous changes. And in tilted disc, it can cause alterations in RNFL peak locations and changes of macular ganglion cell complex distribution. RNFL thickness assessment is an important tool in evaluation and monitoring of glaucoma, whereas in eyes with structural and anatomic variations like myopic tilted disc, it can cause erroneous results. Spectralis OCT GMP edition has a newer objective method of optic nerve head analysis, that is Brooks membrane opening minimum rim width assessment. Here minimum rim width is the shortest distance between Brooks membrane opening and internal limiting membrane and measures the NRR perpendicular to the overlying rim tissue. Aim of a study is to analyze and correlate RNFL thickness and DMO MRW and to correlate the visual field changes. This is a prospective cross-sectional study done in a tertiary eye hospital in 60 eyes with myopic tilted disc and suspicious curve over a period of 1 year. All patients underwent complete ophthalmic evaluation including refraction, optic nerve head evaluation, ovality index assessment, visual field study, RNFL thickness and Brooks membrane minimum rim width analysis. The RNFL thickness and BMO MRW measurements were topographically compared at the level of hemidisc. The 2 superior sectors are included in the superior hemidisc and 2 inferior sectors are included in the inferior hemidisc. A hemidisc is considered abnormal if either or both of the 2 superior sectors or inferior sectors was yellow or red, and either hemidisc, both if both RNFL and MRW are normal or both are abnormal, then they are considered to be topographically agree. Otherwise, they are considered to be disagreeing with each other. And those cases which were disagreeing with each other underwent post hoc analysis. Inclusion criteria to age group 20 to 60 years, best corrected visual acuity more than 6/18, refractive error up to -6 diopters. Exclusion criteria: any non-case of glaucoma, any patient with any retinal pathologies, and those who underwent any ocular surgeries. Results: 55% were males, 45% were females, and about 45% were mild myopes, whereas 55% were moderate myopes. The average RNFL thickness was higher in the inferior hemidisc. The average BMR-MRW was also higher in the inferior hemidisc in our study. Coming to agreement between RNFL and BMR-MRW, out of 120 hemidisc analyzed, 106, 85.83% showed agreement, whereas 14.16% showed disagreement. That is, 14 eyes showed disagreement. Mild myopia patients also showed good agreement, that is 19.7% showed agreement. Moderate myopia also showed 87.17% showed good agreement. Out of 60 eyes, 45 eyes had normal visual fields, whereas 15 eyes showed defects, visual field defects, which was not meeting all of Anderson's criteria. The 14 hemidiscs which showed disagreement underwent post hoc analysis, and the number of false positive plus false negative of MRW was higher than that of RNFL, and that is not statistically significant. The causes for disagreement was missed local defects, peripapillary atrophy, and shifting of RNFL peak. So in our study done in myopic tilted disc and suspicious cup, 85.83% hemidisc showed agreement, whereas 14.16 showed disagreement. That is, 14 hemidisc showed disagreement, and the causes of disagreement were missed local defect, shifting of RNFL peak, and peripapillary atrophy. A study done by Subramaniam et al. In early glaucoma group showed that 73.9% hemidisc showed agreement, whereas 26.1% showed disagreement, and the causes were borderline significance level, local defects, and aberrant blood vessels. A study run by Robodetti et al. Showed that BMR-MRW had higher overall specificity than RNFL measurements. Conclusion: the number of false positive plus false negative in BMR-MRW was non-significantly higher than RNFL. The BMR-MRW and RNFL measures agreed in majority of hemidisc and disagreed only in 14.16% of hemidisc. So those cases who showed disagreement should be followed up regularly, and GCC analysis can also be done to detect these glaucomatous changes in pre-perimetric glaucoma. These are my references. Thank you.
So that is 16%. What shall we do? Which had that disagreement? What more can we do?
In those 14%, we cannot rely on this both BMR and or RNFL. We have to either go for we should do a thorough clinical evaluation, correlate with the RNFL, BMR, and visual field studies also, and we should come to a conclusion at our own discriminant, at the clinician's discriminant. And if at all if it is possible, ganglion cell complex analysis can be done, but it is costlier.
Very good. So that is what I wanted to highlight, that in glaucoma analysis, functional parameters are more superior than anatomical parameters. Second, if you are going to lie down, put your whole weight on an anatomical parameter, then you'll have to double check whether both the eyes are similarly behaving.
Okay.
If the myopic case of equal myopia on either side, then whether these ratios are correct. Or in an anisometropic case, is that difference also there in these ratios? You should validate. That you haven't done. So whenever I see high myopia being the most favorite topic of our study. I think every iota of high myopia has been analyzed by postgraduates in their dissertation. So whenever you are doing, I'm not sure why you are not comparing both eyes. That is the easiest thing to compare. No? That you should compare here.
If a patient has bilateral tilted disc, what's the most common visual field defect you'll expect them to have? A classically tilted disc.
Like they have, like paracentral scotoma can be there.
No, it's a PPA parallel scotoma. The tilted disc.
Arcuate, early arcuate.
They'll have bitemporal visual field defects, but they will not respect the midline. They'll cross over. There'll be spillover in the nasal fields. Okay, so for some reason, if you're going to get a visual field tested done in patients with a high myopia or myopic tilted disc, and you find temporal defects which do not respect the midline, okay, do not get scared suspecting that the patient is going to have a pituitary lesion. Okay, these patients can have these visual field defects. But if you see that the temporal defects are there, bilaterally, it's always better to rule out by getting MRI done to rule out they do not have a neurological issue.
Same thing, different manner I'm asking the question. She told bitemporal hemianopia. This tilted disc produces bitemporal hemianopia is called as what? Hello, bitemporal hemianopia normally you know, no, chiasma area.
Yes.
But here she told no bitemporal hemianopia, not respecting the vertical meridian. In a case of tilted disc is called as what? Bitemporal hemianopia. You fill up the what? It's not real, man. Hello. Then you tell the answer now. It's not real. Hello, real bilateral occurs in chiasma. Here it occurs in the retina problem, nasal retina problems and all is there. Now tell me. A pseudo, use a word pseudo, man. Pseudo bitemporal hemianopia, that's all. The name. There are so many pseudos in ophthalmology, you know that? Normally I used to ask questions, come on, tell me how many pseudo are there in the ophthalmology for fun. They have to, in the exam they have to tell, at least 1, 2, 3 narrate, they must tell how many pseudos are there. Like that you will ask. I have to follow. Okay.
Thank you, sir. Thank you, Dr. Pooja. Next speaker is Dr. Hanna Usman.
Good evening, everyone. My study is on effect of eye makeup and computer use on meibomian gland function among adult females. So, why this study matters? Since the eye cosmetic use has increased dramatically among young women and the daily screen time has also risen. But these factors independently affect the meibomian gland, but their combined impact lead to sinus damage. Since the meibomian gland dysfunction contributes to almost 70 to 80% of evaporative dry eye, understanding these modifiable lifestyle factors is extremely important. As of now, limited Indian data was available and no Kerala-based data was reported. So we know meibomian glands, they produce the lippy layer of the tear film and which prevents evaporation and maintains the ocular comfort. So any obstruction or alteration in this gland can destabilize the tear film and lead to dry eye. So how eye makeup affects the meibomian gland? That's eye makeup contribute to gland dysfunction in several ways. Eyeliner particles may migrate into the gland and mascara flakes may disrupt the tear film stability. And inadequate makeup removal lead to chronic plugging and waterline kajal applications, which is very commonly used, directly block the gland openings and worsens the obstruction. Next is how computer use affect the meibomian gland function. That is, prolonged screen time may reduce the blink rate and increase the tear evaporation, which lead to stagnation of meibum inside the glands, accelerating the dropout and worsening of dry eye symptoms. So, our primary objective was to evaluate the impact of eye makeup on meibomian gland health in females, and the secondary objective was to compare the gland function between the heavy screen users, defined as more than 5 hours per day, and those with lesser screen exposure. So, coming to study design and participants, this was the prospective comparative cross-sectional study. We included 186 adult female subjects divided into 3 groups of 62 each. Group A are the makeup users with more than 5 hours of screen time, and Group B is makeup users with 5 hours or less. And Group C is non-makeup using controls. And we included adult females, both with and without makeup habits and with varying screen usage. And we excluded subjects with active ocular disease, contact lens wearers who underwent recent ocular surgery, suffering from Sjogren's syndrome or isoretinal use. So key measurements include, first is OSDI based symptom questionnaire, next is tear breakup time to assess your tear film stability, next is lid margin examination for any vascular irregularity, next is shimmers to assess your tear protection, lipid scan in order to image the meibomian glands, and the gland expressibility to assess the meibomian quality. And this slide highlights the makeup use pattern assessed in our study. We evaluated how frequently the participants were using either eyeliner, mascara, or kajal. We also documented the total number of years they have been using the eye cosmetics. We also assessed whether they are following a proper removal habits or not. So, this slide shows the distribution of makeup habit, but we found that 80% are kajal users, 60% are eyeliner users, and 50% are mascara users. And out of this, 30% are following a daily makeup removal habits. So, in this OSDI symptom score bar chart, which shows that the group A, which reports the highest OSDI values, consistent with severe dry eye symptoms, and group B has moderate symptoms, and group C reports the least discomfort. In case of tear breakup time, the group A again shows a poor tear film stability reflected by the lowest tear breakup time values, and group B shows moderate stability, and group C exhibits the longest tear breakup time. So here we can see a normal T-bud pattern. The tear film is smooth and there are no early dark spot after the blink. The breakup occurs only after more than 10 seconds, which indicates a healthy and stable tear film. But in this slide, you can see a shorter T-bud. The dark breakup areas appears very early, that's within 5 seconds of the blink. This shows the tear film is unstable. This bar chart compares the shimmer values across the group, and the group A, which shows the lower shimmer score, indicating the reduced tear protection. And group B has slightly better values, while group C, the non-makeup control, shows a higher tear protection. Next, coming to lipid scan, which is a non-invasive infrared imaging technique to visualize the meibomian gland structure, and it provides details on gland dropout, shortening, tortuosity, and atrophy. And views a gradient scale, the grade from 0 to 3. The 0 means no loss, 1 is less than 1/3 area of gland loss, 2 is 1/3 to 2/3 area of gland loss, and 3 is more than 2/3 area of gland loss. So it's a Meibomian score bar chart, which shows a clear gradient that increasing gland dropout from group C to group B and higher in the group A. Here we can visually appreciate the differences. In the case of group C, it shows the near normal gland structure and the architecture was maintained and no areas of gland dropout seen. In the case of group B, which shows the moderate changes, and the blue area indicate the kajal deposition along the lid margin near the gland orifices as well. And we can appreciate how pigment colors at the orifice level. Here, in the case of group A, we can note the kajal stain at the lid margins and area of gland dropout, thinning and distortion can noted, which illustrate the mechanical and obstructive effect of cosmetic residue in the case of habitual users. So, dry eye severity varied significantly across the group, and daily makeup use was associated with poor T-bud, higher Meibomian score, and higher OSDI symptom score. So, this chart compares the overall dry eye severity. That is, group A again shows the highest proportion of moderate to severe dry eye. The group B is intermediate, and group C maintains mostly normal to mild values. So, overall, the finding demonstrates that daily makeup use, especially when combined with prolonged screen exposure, may lead to worsen the symptom, poor tear metrics, and greater meibomian gland dropout. So, to conclude, eye makeup and prolonged computer use may significantly affect the meibomian gland length. We recommend avoid intramarginal makeup like waterline kajal application, ensuring thorough makeup removal, maintaining lid hygiene and warm compresses, and optimizing screen habit using 20/20 rule and blink training. These are my references. Thank you.
So you told about mascara or kajal, no? We got impression on the conjunctiva.
Yeah.
You shown picture, no?
Yes.
Suppose in India, if you see small girls having this kajal or something or the conjunctiva, black spots, what's the inference? If black spots, normally kajal when you adhere, it's not going to adhere. It's not going to adhere the conjunctiva, like it's getting washed out with the tear fluid. But now it's getting attached, means what's the inference now? You are in India, hello. I'm telling you, you're not talking about Japan and all these things. We are in India. Small girls. India only, and some countries, we use kajal. Others not using.
No, everyone is using.
They are using. But you tell me now, kajal adient conjunctiva in small children, that too girls in India, should excite the suspicion of what? No idea. Vitamin deficiency, man, hello. Dry eye, vitamin deficiency, kajal can get idea. That's why whenever you see black spots in the conjunctiva, always suspect. Understand now?
Yeah,
Can you tell me the name of the sign? You know the name of the sign?
vitamin deficiency.
That's called IMTAZ sign. IMTAZ. IMTAZ. That's called IMTAZ sign. Sign means Kajal adheres to the. My Viva questions, please remember. I may come as examiner for you. You are which college?
I'm first year, sir.
Huh?
I'm coming from
First year. You are first year.
Yeah.
But you'll become as third year also, you'll go, no?
Yeah.
Okay, thank you.
We appreciate the idea that the study is very nice, but a lot of variables you add as your first year, you add all these variables. You see, the study is like one broom sweeps all approach shouldn't be there. It's your study is like all non-vegetarians have more heart ailments. It's as if it's so very generalized like that. It shouldn't be like that. You should say like water soluble things this much damage it causes. Lipid soluble cosmetics produce this much damage. The cosmetic wear time and the wear schedule daily, once weekly creates this much. Add-on effect. Contact lens wearers, computer users with the cosmetics, how they add on and create more damage. Like that, you create lot of subtables and bring out some inferences. Okay, right, good. We appreciate this.
We can also emphasize on, computer vision syndrome and the hygiene, what they can follow. So even if they're not ready to not apply, not ready to give up makeup, if they follow strict schedule of 20-20-20 and other recommendations by the computer vision clinic, it will be still better. They can avoid all this. Okay. Thank you.
Nafisatul Misria. We are actually short on time, so please quickly go and start presenting.
Good afternoon all. I would like to present our journey on tactile, which is a tactile marker on eye drop for patients with low vision. Imagine a visually impaired patient has been prescribed with 3 or 4 different types of eye drops. The biggest challenge here is identifying which drop to use now and how many times a day and how many drops. These patients always need someone assistance to administer their drops, makes them more dependent on caregivers, dropping their confidence, which may result in missed doses, medication errors, compromised recovery, and complications. And studies have documented cases of inadvertent use of both ophthalmic and non-ophthalmic eye drops, highlighting this as a significant issue. Many of our patients are struggling with the same issue, so there has to be a better way. So our question was, how can we create a practical and affordable solution to help visually impaired patients instill their drops independently? Our answer to this question is Tactile, which is a touch-based marker system on eye drop bottle for patients with low vision. Tactile basically composed of a label embosser machine, which is available in all online platforms like Flipkart and Amazon for less than 1,000 rupees. And it is used to create raised numerical marking by pressing at desired alphabet or number. And this label strip roller is refillable to the same embosser machine, make it more economical solution. An embossed strip is one side sticky, is then attached to the eye drop bottle. And patient is trained to touch and feel the vertical lines, and the number of vertical lines implies the number of times the eye drop should use. And instead of this line, we can press any numbers. For example, if we want our patient to put 2 drops at 4 times, we can press the number 2 at 4 times. And this is how we use the tactile system, making the embossed label marker by pressing at number 1 or the alphabet I, and cut the label by pressing at a scissors option, and it is attached to the eye drops. And the whole process will take less than a minute only. It is very time consuming process. So for evaluating the impact of tactile, we conducted a study to compare the treatment adherence, patient satisfaction, and medication error rates between patients with standard eye drop application and tactile labeled eye drop applications. Our intervention group consisted of 50 postoperative VR surgery patients who received tactile labeled eye drops, and our control group consisted of same number of VR surgery patients who uses usual eye drops without a tactile marking. And patients with cognitive disorder affecting touch are excluded from the study. It was a prospective questionnaire based study which was conducted in a tertiary eye care center in North Kerala, and sample size was 100 postoperative VR surgery patients, and data collections was done within a period of 6 months. And patient is trained to use the tactile system within 1 to 2 minutes on the day of surgery, and patient feedback is taken by a structured questionnaire based on Likert scale at the end of 1 month when they are coming for their second postoperative visit. And questionnaire mainly consisted of 6 variables: whether they maintained correct dose and dosage, did they miss any dose, independent installation possible or not, how easy was it to instill the drops, how satisfied they are with their eye drops, and about the symptom improvement. These were the 6 variables. And result shows that 84% in the tactile group were able to maintain the correct dose and dosage against 60% in the control group. And there is less incidence of missed doses in the tactile group comparing to the control group. And 82% in the tactile group reported easy eye drop installation, Likert score more than 4. And most important good thing about the tactile is 78% of them were able to manage their eye drops by themselves. And there is little difference in the symptom improvement, but tactile group was still better, and overall mean satisfaction score is 4.5 out of 5 in the tactile group against a 3.2 score in the control group. So, tactile is a simple and cost-effective scalable tool which improved treatment adherence, hence less medication errors. It promoted self-installation and reduced caregivers' load in post-operative VR surgery patients. And we also noted that patients with worse visual acuity benefited more from tactile. So concluded as introduction of tactile markers on ophthalmic medication enhances patient safety and reduces medication error among visually impaired patients. It promotes independence and thereby boosts their confidence. It has potential for smart integration and is suitable for widespread clinical implementation. We hope it brings smile on their faces. These are my references. Thank you.
Just one question from my side. How comfortable are they if they have to use more than one drop? If it's only one drop, it's fine. But if they have to use 2 to 3 medications, have you checked with them?
Yes, sir. Yes, ma'am. We can press the number 2 in label embosser machine. For example, if we want our patient to put 2 drops at 4 times, we can press the number 2, 2, 2, 2 at 4 times. And the patient can touch and feel it. It is 2.
What if 2 medications have to be applied twice? I mean, the same dosage, BD, 2 different medications?
Yes, ma'am. It can do. We can emboss the label marker on 2 medication differently, and patient can touch and feel it. Patient, they cannot identify which is this drop. They cannot identify this is antibiotic or this is lubricant, but they can identify the dose. The timing will be correct, and number of drops will be correct, but they cannot identify which is steroid, and we don't want to them to identify which this drop. Thank you.
Thank you, Nafisatul Misriya. Next speaker is Dr. Hari Krishnan.
My topic is analysis of retinal microvasculature in retinal vein occlusion using ultra-wide field optical coherence tomography angiography. So retinal vein occlusion is one of the most common retinal vasculopathies with a global prevalence of 0.77% among people from 30 to 89 years of age. Based on site of occlusion, there are 2 types of retinal vein occlusion: the central retinal vein occlusion and the branched retinal vein occlusion. The aim of our study is to compare retinal microvasculature features between eyes with retinal vein occlusion and age-matched controls using ultra-widefield optical coherence tomography angiography. Materials and method. This was a retrospective cross-sectional study in a tertiary eye hospital in South Kerala, conducted involving 15 eyes diagnosed with RVO, which included 5 eyes with CRVO and 10 eyes with BRVO between the age of 55 to 77 years of age between November 2024 and May 2025. Inclusion criteria included those diagnosed with retinal vein occlusion on presentation, and exclusion criteria included those who had any other retinal pathologies. We used the ultra-wide field swept source OCT and ultra-wide field swept source Octa images, and they were captured using the Intereye Dream SSOCT system. Swept source OCCs uses a longer wavelength and use photo detectors instead of CCD cameras, which are used in the HD OCT, which increases resolution. And they have a higher scan speed, which is twice as of the SD OCT devices, thus allowing us to obtain wide field B scans and more accurate 3D imaging of the vitreous retina and choroid. The Dream SSOCT has significantly shorter acquisition time for Octa images and a high scanning rate compared to the Spectralis OCT with the scanning rate. The features investigated were the foveal avascular zone, which was measured using the manual caliper tool in the system. And then we looked at the vessel density of the superficial capillary plexus and deep capillary plexus. And we divided the area into the central region, which composed of 107 millimeter square area at the central region, and the peripheral region compared the rest of the image captured by the system. And we also measured the central foveal thickness. The results were cases showed an increased foveal avascular zone area, and in the vessel density, cases show a decreased vessel density of the deep capillary plexus in the central and peripheral area compared to the controls. And then the superficial capillary plexus cases showed a decreased vessel density in the central area. And when looking at the deep capillary plexus in the peripheral region, the central retinal vein occlusion cases showed a more decreased vessel density than the branch retinal vein occlusion cases. And at the superficial capillary plexus level, they were also showed decreased vessel density in the peripheral region, more for the CRVO cases than the BRVO cases. The cases also showed a increased central foveal thickness compared to the controls. The cases also showed a negative correlation between the foveal avascular zone and the vessel density of the peripheral deep capillary plexus and superficial capillary plexus. The foveal avascular zone increased with decrease in the vessel density of the peripheral and vice versa. So in this study, we see that the cases showed significantly reduced central vessel density in both superficial capillary plexus and a deep capillary plexus, and also lower peripheral vessel density in deep capillary plexus compared to the controls. Vessel density of the deep capillary plexus of the peripheral region of the CRVO cases is lower than the BRVO cases, but is not statistically significant. And foveal avascular zone area and the central foveal thickness were higher in cases. So our study and other similar studies showed an increased foveal avascular zone area in cases with retinal vein occlusion and a lower peripheral and central superficial capillary plexus and deep capillary plexus vessel density in cases than in control eyes. So, ultra-wide field swept OCC angiography facilitates the evaluation of retinal vasculature beyond the posterior pole, enabling better characterization of the ischemic changes in RVO. Therefore, it may serve as a valuable non-invasive tool for guiding treatment decision, assessing prognosis, and monitoring disease progression in the future. So these are my references. Thank you. When the foveal avascular zone increases, there seems a decrease in the vessel density of the deep
How
capillary.
do you explain?
So I've looked.
Actually, the way I look at it, arterial occlusion, there can be a decrease in vessel density. In a venous occlusion, there is stasis and retention. No, why should the capillary disappear? The capillary should be there engorged with blood. Blood is not able to return back. So that thing is there. Slowly, we feel that the links which you are establishing are very superficial. So you'll have to like create a bigger base of patients and try to work it up so that we'll have some solid conclusions. Thank you.
Thank you, Dr. Hari Krishnan. Next speaker is Dr. Arya Lakshmi.
Good evening. My topic is analysis of radiological features, systemic risk factors and treatment outcomes in dacryoadenitis. Dacryoadenitis is the inflammation of lacrimal gland. Patient present with features of inflammation with a global incidence of 1 in 10,000 ophthalmic cases. On examination, you will see enlarged and erythematous lacrimal gland. Causes can be many, infectious or non-infectious. Radiology shows lacrimal gland enlargement with sometimes involvement of extraocular muscle, intraorbital fat or paranasal sinus. Treatment is based on etiology of the disease. The aim of my study was to analyze the radiological features and to correlate with the systemic immunological risk factors and to evaluate the treatment outcomes in dacryoadenitis. It was a retrospective observational study conducted in Tertiary Eye Care Center. Patients with the diagnosis of dacryoadenitis for a 2-year period were selected. Inflammation secondary to thyroid eye disease, neoplasm and trauma were excluded. So, the patients diagnosed clinically as dacryoadenitis were selected. Demographic details, systemic and ophthalmic history was collected. All the patients have underwent CT orbit and image was analyzed for the involvement of lacrimal gland, extraocular muscle, orbital fat and paranasal sinus. Blood investigations were sent to look for serological immunological markers. Patients were started on systemic steroids and on day 3 response was analyzed. And it was categorized as no response, complete response or moderate response if the response was in between first two. Rheumatology opinion taken if serological markers were positive. Further follow-up were done on week 1 and week 3. So we got a sample size of 50 with mean age group of presentation as 48.32 years and females were predominantly affected. Looking at the blood investigations, 37.5% of the patient had elevated anti-nuclear antibody, 33.3% had elevated serum IgG4, 16% had elevated serum angiotensin converting enzyme, 7% had elevated RA factor, and none of the patient were positive for anti-neutrophil cytoplasmic antibody. Looking at the radiology, out of 50 patients, 21 had extraocular muscle involvement, 8 had bilateral lacrimal gland involvement, 6 had intraorbital fat involvement, and 2 had paranasal sinus involvement. Lateral rectus muscle was the most commonly involved muscle in patients with dacryoadenitis. Looking at the radiological imaging of IgG4 positive patients, out of 9 patients, 5 had unilateral lacrimal gland enlargement, 4 had bilateral, 3 had associated extraocular muscle involvement, 3 had paranasal sinus involvement, and 4 had intraorbital fat involvement. Here we could see that 89% of the patients with serum IgG4 positivity had 2 tissue involvement in radiology. That is either opposite eye lacrimal gland or extraocular muscle or intraorbital fat or paranasal sinus. Similarly, radiological analysis for ANA positive patients were done. Out of 15 patients, 11 had unilateral lacrimal gland enlargement, 4 had bilateral, 3 had muscle involvement, 2 had sinus involvement, and 9 had intraorbital fat involvement. Here also we could see that 93% of the patients with ANA positivity had 2 tissue involvement in radiology. Looking on to the treatment response to systemic steroids, on day 3 and week 1, majority of the patients had moderate response, whereas on week 3, majority had complete response. But for serum IgG for positive patients, on day 3 and week 1, none of them had a complete response. And even on week 3, majority had a moderate response only. Similar was in case of ANA positive patients. Majority of the patient had a moderate response only during all the follow-ups. So what here to highlight? Radiology helps to assess the extent of orbital tissue involvement in dacryoadenitis. The involvement of lateral rectus muscle can be attributed to the contiguous inflammation from lacrimal gland. Whenever there is multiple tissue involvement associated with the lacrimal gland in radiology, patients are more prone for an immunological cause. Loom, Samran et al. Have conducted a biopsy-based study to look for the specific cause of dacryoadenitis. Here he have found out 61.7% had a specific cause. And in our study also, just looking at the blood markers, we also got a similar percentage of 62. Even though majority of the patients had complete response to systemic steroids on week 3, for ANA positive and IgG4 positive patients, majority had a moderate response. That highlights the suboptimal response to systemic steroids at week 3 warrants an evaluation by a rheumatologist. These are my references. Thank you.
Infective mumps related adenitis, inflammatory related, autoimmune related adenitis, we'll have to differentiate. We'll have to put two subsets. They are not one and the same. Okay. And when this becomes adenitis and when we'll call it as pseudotumor or IOID, we'll have to be clear. So these two factors are not looked upon. Otherwise, it's a good study. You are trying to bring us good inferences, but these two has to be validated also.
Last time when IgG4 is positive, you must do MRI because you rule out pachymeningitis. Those they are asymptomatic. So whenever IgG4 is positive with dacryoadenitis, make sure MRI is done.
Thank you, everyone. I think we can move on to the next session. Thank you, judges.